Good afternoon, everyone. We'll start in just a few minutes. Waiting for folks to join. Welcome. Welcome, everyone. We'll start in just a minute. Good afternoon, everyone. We'll start in just a minute. Feel free to, we have the chat open. Feel free to use it during our talk, but we'll give folks one more minute. All right, well, I think we can go ahead and start, team. Wonderful. Okay, well, I know folks are joining, but while we're letting folks in, I think we can go ahead and get started. And welcome, everybody. You're here for our webinar, Building Sustainable Nutrition Partnerships, Implementing Texas House Bill 26 and Senate Bill 25. The webinar is brought to you by Center for Health Law and Policy Innovation at Harvard Law School and UTHealth Houston Center for Healthy Communities. Before we jump into our presentation for today, which we are very excited about, just a little bit of housekeeping. Feel free to keep your cameras off and your microphones off during our webinar presentation. If you have any questions that pop up, feel free to put them in the chat. And we will have time for Q&A as well. So at the time, feel free to come off your mute buttons and turn your cameras on. And we look forward to an animated conversation. So welcome again. If you can jump to the next slide. I'm Shrila Sharma. I'm a professor of epidemiology at UTHealth Houston School of Public Health, also director of Center for Healthy Communities. It is one of our research centers at the school. And we have been working for the past, well, over a year with our colleagues at Chilpy around policy and how do we build evidence-informed policy in the state of Texas, specifically around food as medicine work. At the Center for Healthy Communities, we have, in addition to the policy efforts, we have work that's happening in building core infrastructure to do work in social determinants of health or non-medical drivers of health, as we call them. For example, many of you are involved in our coalition efforts and Coalition for Connected Care. It's a collective impact effort to primarily improve care coordination for non-medical drivers of health. We have data analytics efforts to really build out insights in this space of non-medical drivers of health. And then we have a lot of work that's going on in this space of designing interventions and programs and evaluating if they work. And within this space, we have a robust portfolio of food as medicine-based programs and interventions. Sorry, can you go back? I don't know. Um, just want to call out the QR code down at the bottom if you are interested in learning more about the work that our faculty, students, and staff are engaged in. Feel free to look at our website and look through all of the work that we are doing. And we look forward to all of our work happens through partnership and collaboration. And so we look forward to hearing from you as well in that regard. Next slide. Just wanted to share a little bit on our Food as Medicine core at the Center for Healthy Communities. There's research, education, and practice, which are the three pillars that our entire School of Public Health really works on. The Food as Medicine core is also centered around those three pillars. Primarily, if you look at this figure that you see in front of you, going from 1 through 6, we have work happening where we are supporting health systems and community organizations in assessment and design, what types of food as medicine programs best fit the population of interest, what types of partnerships need to come together so that we can meet the communities where they need us at, training and capacity building to develop food as medicine interventions, including getting funding for implementing this type of work. And then once we are in the implementation phase, thinking about implementation outcomes, what are the metrics of success, looking at the impact of these types of programs, and then what is needed to sustain or scale these types of programs if they're found to be effective. Again, if you want to learn more about the work that we're doing in partnership with many, many organizations, including the ones that you're about to hear from today, please visit our website. All right, so next slide. Without any further delay, I'm very excited to welcome our speakers for today, starting with Erica Hansen, who is Clinical Instructor of Health Law and Policy Clinic at the Center for Health Law and Policy Innovation at Harvard Law School. I've had the pleasure of knowing Erica for a couple of years, and it's been an absolute pleasure to work with her and the rest of the team. Also joining Erica is Kristen Monroe, who is a clinical fellow of Food Law and Policy Clinic at the Center for Health Law and Policy Innovation. And then we have our two Houston-based colleagues, Josh Fernelius, who is Director of Population Health at Community Health Choice, and Jasmine Lanner, who's Nutrition and Partnership Senior Manager at the Houston Food Bank. So absolutely powerhouse team here who are going to share a lot of great insights. So to kick us off, I'm going to pass it to Erica to get us going on the rest of the webinar.
Thank you so much, Srila, and to the Center for Healthy Communities and your coalition, and for all of you for having us here today. For those of you who aren't familiar, the Center for Health Law and Policy Innovation of Harvard Law School advocates for legal, regulatory, and policy reforms to improve the health of underserved populations with a focus on the needs of low-income people with chronic illness. Overall, CHLPE, as we're known, works with a wide variety of partners and others to expand access to high-quality healthcare and nutritious, affordable food. CHLPE is a clinical teaching program of Harvard Law School, so we mentor students to become skilled, innovative, and thoughtful practitioners, as well as leaders in health, public health, and food law and policy. We're comprised of the Harvard Law School Health Law and Policy Clinic and the Harvard Law School Food Law and Policy Clinic. So thank you so much again for having us here today to talk about this important policy development in Texas. So first, we're going to provide a high-level overview of Texas House Bill 26 and what it makes possible in the state. So first, HB 26 explicitly recognizes nutrition support services as what's known as in lieu of services within Texas Medicaid managed care. So in practice, that means that Medicaid managed care organizations in Texas can provide certain medically appropriate, cost-effective, and evidence-based nutrition services when it makes clinical and financial sense to do so under federal and state regulations. So this law does two key things. First, it authorizes Texas's state Medicaid managed care plans to offer those evidence-based nutrition counseling and instruction as a covered in lieu of benefit for eligible members. Second, it creates a pilot program focused specifically on pregnant enrollees who have a chronic health condition or disease that may contribute to high-risk pregnancy or birth complications. For this high-risk group, plans can offer more intensive nutrition support services. So within that pilot, nutrition supports can take several forms. So we can have that standalone nutrition counseling and instruction, medically tailored meals paired with counseling and instruction, or even other evidence-based nutrition interventions. So that could include things like produce prescriptions or medically tailored groceries. HB 26 also requires evaluation of how these pilot services affect maternal and infant health outcomes in the state. That evaluation can help the state, plans, and other stakeholders determine whether and how these services can be scaled statewide. Finally, this law goes into effect or went into effect September 1st. And at a House hearing yesterday, it was reported that implementation is expected in September 2027 to align with the state's timing of MCO contracting. Between now and then, there is a really important window for Texas health plans, providers, and community partners to prepare for implementation. So to build referral pathways, to identify or train nutrition providers, and to design programs that are medically appropriate and cost effective as those in lieu of services.
Great. Thanks, Erica. So turning now to SB 25, this law actually establishes a nutrition education framework for healthcare professionals and students across Texas. So we've kind of been calling this a pipeline approach to nutrition education for healthcare providers because it actually touches on every stage of medical education. So diving into the requirements of this law, all state-funded health-related institutions must incorporate nutrition curricula for medical students and then other students in health-related fields, as you can see on the screen. And then it also requires health licensing boards in Texas to require continuing medical education in nutrition and metabolic health as a condition of that license renewal. Importantly here, the curriculum and the specific duration and content of the continuing medical education is going to be based on the Texas Nutrition Advisory Committee, or TNAC, guidelines and recommendations. So this is another aspect of SB 25. It establishes TNAC, which is charged with many things, but basically investigating the impact of diet, nutrition, and ultra-processed foods on health, conducting a review of the evidence on the health effects of ultra-processed foods, providing education on those effects, and then developing and maintaining the dietary and nutritional guidelines, again, that the State Board of Education and the licensing boards will be using to develop that nutrition education curricula and CME content, respectively. And then TNAC, by September 1st of each year, must report on their work and present their nutritional guidelines and recommendations. So we're going to touch on this a bit later, but there is a lot of opportunity for engagement with TNAC currently and in the future as well. So with that, I'm going to turn it over to Josh and Jasmine to talk about community health choice and how it represents a great example of an existing community healthcare partnership in the state of Texas.
Thank you so much. Well, it's great to be here with all of you to share learnings from our multi-year partnership with the Houston Food Bank. Our partnership is called FoodRx. This actually began in 2022 as a Texas Health and Human Services Commission performance improvement project. We call it a PIP. And the topic was Medicaid high-risk maternity. And really, what we were trying to do was address persistent maternal health challenges and poor outcomes, not just in Texas, but particularly within our region. And so the objectives were to identify a high impact non-medical need, and then implement a scalable intervention, and of course measure the results. So based on our longstanding experience serving this population, we saw that the consistent barrier was that although our beneficiaries might be engaged in their maternal health care, nutrition guidance or dietary habits were hard to follow without reliable access to healthy food. And that's really why we partnered with the Houston Food Bank and built a managed care pathway around FoodRx. Jasmine, is there anything you want to add?
Yeah, thank you for that. And thank you for this opportunity. And just to kind of piggyback off of Josh, I think for us, we already had this program established, and being able to meet the needs of the moms by providing screening and getting them connected to food was just a no-brainer. So this partnership has been really awesome in a sense of learning all the ways that we can provide insight to really make this work become sustainable and scalable. Thank you, Josh.
Yes, thank you, Jasmine. All right, next slide. Okay, so a little bit about Community Health Choice. So we're a nonprofit managed care organization that was launched by the Harris Health System in 1997. And so our mission is really to improve the health and well-being of Texans, particularly the underserved, by opening doors to healthcare and health-related services in the southeast region of Texas, which includes Harris, which I think it's kind of in the middle there, and 19 surrounding counties. And so our mission really shapes how we look to identify community partners. But of course, there are other ways, other areas of how we do this, including the mission-driven fit, having a local footprint, having that evidence-based model, making sure that that equity is at the center for our beneficiaries. And then, of course, that last part, which we could probably have a whole webinar on, which is really managed care readiness. And what does that take? Next slide. So our approach for high-risk maternity, it's really a life cycle, and it's designed to be a seamless whole person journey through an assigned care manager. And then through that, we have standardized handoffs across settings, and really trying to build intentional support during care transitions. This could be, something like a high-risk delivery or a NICU birth. And so for FoodRx, we really treated the handoff as the intervention here. That really simple referral to enrollment pathway, following up when the barriers present, and then of course tailoring the support by risk throughout the prenatal and the postpartum period, so that members can consistently use the benefit. And we integrate a non-medical driver of health screening. This was actually legislation that was passed for the maternal Medicaid population. And so we use that to connect members directly to resources for food, housing, transportation, and childcare, because those barriers are often why these great care plans fail. And so FoodRx fits really well into that journey, because it wasn't just a standalone giveaway. It was coordinated support. It was connected to the overall strategy for how we do care management, but of course having that closed loop tracking as part of it as well. Next slide. So in addition to that life cycle, I think one of those areas, or really the recipe for success, really comes down to how we integrate community health workers into the approach. So integrated services are really grounded in a model that expands access, supports prevention, and then of course helps engage the more difficult to reach populations with community-based support and follow-up. And so I really think that the community health workers reduce friction. They say things with plain language around benefit education, appointment support, barrier resolution. They're very culturally responsive in how they engage, and of course, they navigate our beneficiaries to programs like FoodRx, and I really think that is one of those great things about community health workers. And so, of course, in FoodRx, the CHW enabled part of the workflow is really what became the difference between referral and redemption. So being able to place warm handoffs, troubleshooting barriers, whether that was difficulty accessing the system, was it transportation, was it just language that the member of the beneficiary maybe didn't understand, and so that really helped us develop a way to intervene when that member's utilization dropped, when something went wrong. So we were able to quickly jump into that and figure out what was wrong. Next slide. So I think another really important piece here is that the way that we organize this work, particularly the non-medical driver of health work, is done through a pillar-based approach. And so as you can see here, that includes more than just the food and nutrition, but when we talk about the FoodRx example, that's really an applied example of this pillar approach and how we're really trying to address those upstream drivers of risk and improve outcomes for our high-risk members through interventions that are scalable and measurable. And in managed care, that typically means pairing community capacity, like the food bank, with a health plan workflow. And then with that comes, how do we manage the referrals? How do we ensure enrollment support? How do CHWs promote access? How can we bring transportation solutions into this? And then of course, how do we evaluate and report on the outcomes of interest? Like all of that is really part of the, what I call the managed care readiness for partnerships. Next slide. Oh, Jasmine, I think to you.
Awesome. Thank you so much. And I just wanted to provide some just basic information about the food bank, and then I'll jump a little bit more into the FoodRx program. So I just have our community health strategy here. And for our department here and organization, we really want to meet neighbors where they are. So we have an array of interventions to really connect family members with food access. So we start out with screening. So very much in this case with FoodRx, screening individuals for food insecurity plus a chronic condition, and then getting them connected to the program that best suits their need at the time. So if you look here, we have a couple of different interventions that we currently offer. So we have our first link strategy where we are working with healthcare partners and they're getting neighbors connected with non-food resources. So just as Josh mentioned, as we think about the whole person, sometimes, food is just one aspect where they may need assistance with housing, transportation. So we have partners to connect neighbors there. We also have our nutrition education classes where we provide on-site cooking demonstration, education, and this really is to help the neighbor really utilize the produce that they receive, the food that they receive, and also help increase the knowledge and behavior. Then we have our FoodRx program. I will go all into detail about that next, but it's really a food prescription for individuals with chronic conditions. And our goal is to ensure that they are utilizing it to improve their health outcomes. And lastly, we have our medically tailored meals program, which we recently just started. So we are currently working with individuals with HIV, but we're providing meals specific to their conditions that are being delivered to their homes with the support of a dietitian on our team. So food access is one important piece, but we're also working with our healthcare partners to look at some outcomes. So they could be health related, utilization, as well as other qualitative outcomes. So I have those listed here. And this really just tells a story about the neighbor. The more that they're receiving food, the more that we can demonstrate the quality of life improvement, improvements in their biometrics, improvement in access to food. So it really just paints that entire picture. So this is our strategy to really meet the neighbor where they are. And I also like to emphasize it's not here, but we work very closely with our GR team, so our government relations, so we can provide this insight. So as we think about sustainability, scalability, it's really nice to have that feedback loop to discuss the outcomes that we're seeing. Next slide, please. So our Food RX program, this actually started before my time. We had a really cool idea of people, we know they need food access, but what if we can keep them to come back, right? And not just in crisis. So the purpose of the Food RX program, it started with the idea of if we can keep individuals coming back, maybe we can mitigate some of those trade-offs that we know neighbors have to make. Should I buy my medicine or should I buy food? So with the food bank being the food bank, we bring food as a catalyst. And really the goal of the Food RX program is to stabilize the family member so they can focus on other areas of their life. So with the Food RX program, we currently operate with 25 healthcare partners ranging from healthcare plans, health systems, as well as FQHCs. Um, and we have over 80 sites operating at this moment in the greater Houston area. So how does the program work? So we work with healthcare partners to integrate a screener, 2 questions, hunger vital signs into their workflow. Some healthcare partners have their own, which is great. We just want to make sure that we're integrating that screener into the workflow, plus a chronic condition. So in this case, with Community Health Choice, the maternal population with high risk. So we were screening individuals for food insecurity plus other non-medical drivers of health, and then enrolling the patient from there. So we have a very much Food RX card. It's kind of like our Costco membership, but you receive your card and now it's just an email where you have your ID and then you're able to redeem at our Food for Change market. So if you think about the Houston Food Bank, we have a very large pantry network. However, we have Food for Change markets. So our nutrition education team, equitable access team, they work very closely with these specific markets to make sure that we're ordering produce. We have nutritious food, we have nutrition education, we have those wraparound services to really take care of that whole person. So I really want to say we can't do this work alone, even within the food bank. So we have really awesome teams that are getting the neighbors connected. So once enrolled, patients are able to redeem twice a month. So on a bi-weekly basis, and they can get up to 60 pounds of nutritious food. First, we used to, really push produce. It's like, hey, here's 60 pounds. But, as you think about a person and that whole plate perspective, we started to incorporate lean proteins, whole grain items. So really making sure that that neighbor has the nutritious food. So duration of the program typically now is 12 months. And I believe with this project, Josh, it was 6, correct?
Yes.
Perfect. So yeah, so with this specific population, they were able to redeem twice a month for 6 months total. Next slide, please. And so I will kick this slide off and then I'll pass it back over to Josh to share a little bit more specifically with this evaluation project. You had 3 core partners here. So we had CHC acting as the MCO, the Houston Food Bank as the actual food vendor itself, and then also UT evaluating. So I will just share with you firsthand, it was really helpful to work alongside with the 2 entities. And the call out, I would say, really is that we were able to really understand the capacity of each other. And that really helped us set rule and expectations for us to really make this scalable. So we had a lot of learning opportunities for us to go back to the drawing board to say, hey, this works, but how can we fix this? And so I would say, as we're thinking about sustainability, also understanding the capacity of each partner and really working together to make sure that this is an intervention that could really support that neighbor. So I will pause, Josh, and let you take over.
Sure, thank you. And you know what, I cut off there for a little bit, but I think we actually our partnership was a year long, and that was of course at any point the member was identified in the pregnancy journey, whether that was prenatal or postpartum. And I think that having that sustained benefit as part of what we were doing for care management really played into how well this worked as a partnership. And I think the only other thing I'll say here is that this is really the real world application of research, policy, and practice. And so, for me as a public health professional, that was a very exciting way to be able to look at this work and, to view it through that lens. Next slide. So as I prefaced earlier, our project, our initiative was regulatory driven as a performance improvement project. And so bringing UTHealth in to conduct the implementation, the evaluation of the implementation and the outcomes was key here, because that allowed us to learn as we went along and not really guess at the work. And I think for a lot of the project, we were meeting weekly to discuss barriers, solutions, things we could do differently to pivot quickly. And so when it came to the evaluation itself, it was designed as quasi-experimental of the Houston Food Bank FoodRx among the high-risk pregnant CHC members. And what we examined were selected pregnancy and birth outcomes and 3 or 6 month pre versus post dietary changes. And then, of course, benchmarking that to the state and national averages for the context. Next slide. So when it came to the impact evaluation, I think we really broke it down into what are the outcome signals, what are the diet signals, and then what are the member quality of life related signals. And so when it came to the outcomes, what we saw is that the rates of gestational diabetes, hypertension, low birth weight, macrosomia were lower in the exposed group, food as medicine exposed group, compared to the overall Medicaid population, but there was no clear dose response there. When it came to diet, fruits, whole grains, dairy intake improved. Although overall challenges were not statistically significant, there was a strong statistically significant dose response, which meant that there were bigger improvements when there were more redemptions. And then when it came to the self-rated health, though there was no clear dose response there, although there were significant improvements in self-rated health in the participants over the course of the intervention. I also think there's really a fourth one here, which is the major implementation lessons that we've kind of talked through. But of course, when it came to having CHWs as part of that, I really think that that really reduced the friction and gave us much better engagement over the course of the program. And then of course, those little operational details like handoff timing, having consistent verbiage across teams, and having transportation options. Those all materially impacted utilization as well. But I think maybe more the unsung heroes there. All right, next slide.
Amazing. Thank you so much to Josh, and Jasmine for articulating what a program like this, a partnership like this, looks like in Texas currently, doing amazing things. And at its core, what HB 26 and SB 25 present is an opportunity in Texas to really scale successful programs like this and also provide a sustainable funding source. So programs like Josh and Jasmine's typically are funded through philanthropy or out of the healthcare plan's pocket, right? But HB 26 and SB 25 provide opportunities for that more sustainable funding source. However, integrating innovative community services such as the nutrition support services described in HB 26 and by the practitioners that you just heard from at Community Health Choice and Houston Food Bank into our healthcare delivery and insurance systems can be a barrier to sustainable program success. And so some of those common barriers to implementation of a policy like HB 26 include screening and enrollment of providers, billing and reimbursement for nutrition services, and referral pathways. And then finally, the education received by healthcare providers, which is the subject of SB 25. And so to increase the likelihood of successful and sustainable healthcare integration of nutrition services, stakeholders can consider implementing supportive structures such as clear policy guidance, model practices, and flexibility to allow for gradual compliance with healthcare procedures and to allow payer innovation. And this is exactly what Josh just touched on at the end of his comments. So the first thing that we want to touch on is how can nutrition providers, right, like Houston Food Bank, actually participate in Medicaid? So federal regulations require all ordering or referring physicians or other professionals that are providing services under the Medicaid state plan to be enrolled as participating providers and to be screened using risk-based criteria. This includes things like license verification, disclosures, and federal database checks, and may include site visits and criminal background checks. These procedures ensure that providers meet federal and state qualifications to deliver Medicaid services, including educational, training, and professional standards of conduct. However, there are not mandatory licensing or credentialing systems for many of the kinds of nutrition providers that would deliver services under HB 26, even though these types of providers have been successfully delivering services in the state for years, as you just heard. So when Texas sets qualification standards for nutrition providers, it will be important to strike a balance. We want to protect quality and program integrity in Medicaid, but we don't want to unintentionally exclude the very partners who are already reaching Medicaid members with these important services. So other states have offered helpful models to screening and enrollment of new provider types in Medicaid. And in fact, some have followed Texas's community health worker program that Josh was highlighting, and rely mainly on kind of formal and certification programs that are approved by the state. And that's what Texas does for community health workers. Others create multiple pathways, so like one based on formal training and another based on documented experience, recommendations, and demonstrated competence. In the nutrition space, many states have leaned heavily on those experience-based pathways, paired with clear guidance from the providers themselves about what real-world competence looks like in the field. A next potential barrier to sustainable implementations of policies like HB 26 is billing and reimbursement for services. So once a new nutrition service is authorized, how will plans pay for it? And how will providers get paid? So states and payers need to estimate the current costs for the target populations in the legislation and the expected savings, and then build those assumptions into capitation rates and reimbursement levels. So on the ground, community providers then have to be able to submit bills or invoices in a way that the Medicaid system can process and pay. However, this may not be so simple to actually operationalize. Many community organizations may not have billing departments or claims software, and actually standard codes often do not describe nutrition services very well. And that can slow payment and also make it harder to evaluate the program's impact. States have used several strategies to address these potential problems, including coding guidance that use existing codes plus modifiers to distinguish the different nutrition services and to support evaluation. States have implemented flexible billing options and training that allow paper or invoice-based billing at startup, or require plans to train community partners on claim submission and payment processes. So for example, Wisconsin has released really concise guidance implementing its medically tailored meal in lieu of services policy that includes this training requirement. Model contract templates between plans and community providers can simplify negotiations and ensure that key requirements are consistently addressed across the state. States have also issued fee guidance in order to ensure that fees reflect the true cost of services. So this includes food, delivery, staff time, assessment, and administration. And states have committed to updating fees regularly in partnership with providers. And then finally, some states have used budget allocations to help community providers and plans invest in technology, staffing, and business systems so that they can fully participate in the Medicaid program. And these policies can help ensure that once nutrition services are authorized, quality service delivery can be sustainably supported. Finally, even with all of those other pieces in place, inadequate referral pathways, so how do we actually get a patient to services, can pose a risk to successful program implementation due to communication gaps, confusion among care managers, providers, and payers, and data inoperability. So consequences to this could include service delays, duplicative referrals, and increased administrative costs. So states that have been implementing similar policies have responded in kind of three main areas. So we've seen standardized screening and referral workflows. So this is like using common screening tools, clear referral criteria, and interoperable platforms that can help plans and providers know who is eligible and what happens next. So some states like Oregon encourage or require plans to adopt standard workflows and timelines. So for example, notifying members of approval of services within a set number of days, and then referring to a nutrition provider within a specified timeline. We also have policies of member engagement and individualized care plans. So things like warm handoffs, care plans that integrate nutrition services, and options for members to request services directly, which all can improve follow-through and accountability to ensure that individuals are actually getting to the services described in these policies. Finally, shared data platforms, so things like statewide health information exchanges or social care referral tools, can allow providers to send and receive referrals securely, track status, and monitor outcomes. Features like service directories, closed-loop referral tracking, and reporting and analytics make it possible to see where referrals are getting stuck and where programs are working well. These strong referral pathways are what turn our policy on paper into real services, reaching the people who really need them. So with that, I'm going to turn to Kristen to discuss a final piece of sustaining successful nutrition policy.
Thanks, Erica. Turning back to nutrition education of healthcare providers, historically, it's been kind of excluded from the medical education for healthcare professionals. But recently, since January 1st of last year, we've seen a ton of movement, particularly on the state level when it comes to incorporating some requirements for doctors, physicians, and other health-related fields to receive nutrition education. So even this slide is actually outdated. So last week, Tennessee also enacted a continuing medical education requirement for healthcare professionals. So have to update this slide, but this is just giving you a breakdown of some of the movement that's been happening at the state level and covers some of the content, right, of those pending and enacted bills. So as you can see, most of the nutrition education requirements are related to continuing medical education. And Texas is actually pretty unique in that it's one of the few that touches on both continuing medical education and then those earlier stages of or medical education as well. So then, just to conclude on nutrition education for healthcare professionals, we wanted to highlight some of the other sample approaches or other examples that we've seen in this front. So one is Louisiana, SB 14, which was enacted around the same time as Texas's SB 25. This is specifically a continuing medical education requirement in nutrition and metabolic health for physicians and advanced practice nurses across a bunch of different specialties. So again, that's limited to continuing medical education. And that was, again, one of kind of the first movers on the state level for nutrition education for healthcare professionals. And then lastly, another approach here, we've seen Gaples Institute, which is a physician-led educational nonprofit, has developed an evidence-based nutrition curriculum that's already being required at 13 U.S. medical schools and is available as a course, a continuing medical education course for clinicians, physicians that are already practicing. And as you can see, it really emphasizes the practical nutrition counseling skills to enable physicians and other healthcare professionals to be able to interface with patients and make it a really useful body of knowledge. Next slide, please. All right, to sum it all up, we talked about a lot today, but just to highlight some of the takeaways here, Texas, HB 26 and SB 25 provide a really important opportunity to really harness these nutrition services as a tool to improve health outcomes, reduce healthcare expenditures and utilization, strengthen the economy of Texas, and really position Texas as a national leader in community care innovation. At the same time, even when you have a strong policy in place, there are some common barriers. So just to give an overview of the ones we've touched on, we've talked about screening and enrollment of community providers, billing and reimbursement for providing these services, referral pathways, and nutrition education for healthcare providers. Another point here that we've talked about is the supportive structure. So I think this was really highlighted by Josh and Jasmine's example of their partnership, as well as some of the models that we've presented. Policy guidance, right? Like, let's develop some helpful tools to lead people along in the right direction. Model practices, again, from other states or other existing partnerships, and then flexibility to allow this gradual compliance. So based on these lessons that we've learned, what are some potential next steps to successfully implement HB 26 and SB 25? First, work with HHSC to develop that implementation guidance. Again, that's considering the learnings and best practices and not reinventing the wheel. Second, working with the Texas Department of State Health Services on Medicaid screening and enrollment to allow additional nutrition providers to implement these nutrition services. Third, again, leveraging the existing community healthcare partnerships that exist in Texas and building upon the existing landscaping and policy analyses that have already been conducted to develop capacity to further deliver the services and identify gaps that exist. And then fourth, engage with TNAC. I touched on this a bit earlier, but they are currently seeking subject matter experts to help review and assess evidence about diet and health outcomes. And then along with this, they have monthly meetings, both in person at the Texas Department of State Health Services, Morton Building, or you can also join via live stream and you have the opportunity to provide written or oral comments. So I flagged the date of the next TNAC meeting, which is May 27th. And then they also post the agendas in advance if you want to take a look. So I'll stop there. I'm sure there is more to discuss and probably a lot of questions to address here, but thank you so much.
Thank you so much to all of our presenters. I feel like that was just very helpful, and there's so much information. And so it's great to be able to kind of see how the different pieces and partnerships have come together. Kristen, as you mentioned, there's a lot of questions in the chat and in the Q&A. So thank you for sending those over, and please continue to do so. I just wanted to kind of start off. There's a lot of questions that are kind of related to implementation. So Erica, specifically looking at HB 26, can you give us just a brief overview of kind of where we are at this point in implementation? I know there's a lot of details that people are specifically asking about. And so, how are those details going to be kind of ironed out over this next year?
Excellent question. So the hearing yesterday specified that the goal is to implement this policy in September 2027. And so from now until September 2027, HHSC and the MCOs and all of the partners will be working on those details, right? So how do we screen and qualify nutrition providers? What exact populations are we going to be targeting? What are the referral pathways going to be looking like? So those decisions have not yet been made in Texas. So you all, right, that's where you have an opportunity to look at your existing partnerships, like what Josh and Jasmine presented today, as well as what other states have done. So those examples that I provided, as well as you have a group here that have put together a wonderful fact sheet that we can drop in the chat that highlighted some other examples throughout the country to see what do you think will work best in Texas to successfully implement your policy. So we wanted to get kind of ahead of the ball to present what this policy is and what your options are for implementation. So that's where things are. There's a lot on the table for you to take away from here and think about and work on.
Yes, thank you so much for that, Erica. And I think one of the other questions that has come up, and I know y'all touched on briefly, but if you can talk a little bit more about what are some of these sustainable funding models that y'all have seen across other states as well?
Yeah, that's a great question. And so to circle back a little bit, and I'd love to hear from Jasmine and Josh too about their partnership. A lot of the current partnerships in Texas and in other states that are funding these types of nutrition services are currently funded by philanthropy or healthcare plans. MCOs are paying for them like out of the plan's own pocket. So out of things like marketing dollars or their philanthropy arms. They're not actually coming from their capitation rate, meaning they're not actually coming out of Medicaid dollars or Medicare dollars or commercial insurance dollars, right? So it's all kind of philanthropy, which is great and wonderful, but it's also not the most sustainable, right? When you are on a grant funding, it may be a 1-year grant, a 2-year grant, a 5-year grant if you're lucky, right? And you have to continually reapply for renewal. And so something like an in lieu of services benefit, which is what HB 26 provides for nutrition counseling for the whole population, and in the pilot for some expanded services for pregnant populations, that is more operating like a covered service, right? So it's coming out of Medicaid dollars, which is a more sustainable service or funding stream, more like Medicaid dollars and Medicare dollars. And so when we talk about sustainable funding streams, that's more like what we're talking about. So in lieu of services, or there's some other ways that healthcare plans can pull down actual Medicaid, Medicare dollars to pay for these services.
And then I can jump in there to take this as well. Thank you for that, Erica. And yeah, I agree with you. As I mentioned, our project started as regulatory performance improvement, and so there was no funding on the table. It was bring your teams together. And so really what that meant was administrative expense. So, making sure that when it came to personnel, dedicating 10 CHWs from the community health choice side, our maternity care management umbrella, and having our care managers add into the screening and intake and assessment this referral pathway over to FoodRx. So those were some of the ways that of course our staff were spending time. And then of course when it came to the funding of the program, that was grant funding, including the evaluation piece. Jasmine, I think you could probably talk more about that from your side, how that was blended in. But of course, where we are today, I think we've also looked at value-added services, which is a managed care flexibility. For example, we are looking at bringing in nutrition counseling, because we do have a dedicated SDOH department, or non-medical driver of health department at CHC. So bringing that into our value-added services arrangement is really one way. And then of course tying that to support for those with chronic conditions is really how we're going about that.
Yeah, and I would just add, for the Houston Food Bank, for our FoodRx program, we're really covering this through development dollars, supportive partners. So in some cases, I think Erica mentioned that if we'll work with maybe an MCO, it's coming from their benefits, but there's not truly a pathway yet for payment. So we know that this work is important, so we will find ways to make sure that we're serving our neighbors. But I think for us to be sustainable, for us to scale, to serve the 18 counties that we provide and cover service to, having that in lieu of service or something that can help us always have that continuous funding coming.
And then one more thing I would add, I think, is that when it comes to defining ROI, I really think the evaluation is a key step in that pathway. And so, having this information available really allows us to take the next step to figure that out with the food bank and build towards a more sustainable pathway.
We have time for one more question. Go ahead, Naomi. Heidi, do y'all have any questions?
I see a hand raised there, but I just think I just wanted to say the questions I think are super helpful, and look forward to opportunities in working together to address plans for implementation.
Well, we have time maybe for one more question. Destiny, since you have your hand up, do you want to go ahead and ask?
I think our participants are muted, but Destiny, if you want to put it into the chat, we can answer it that way as well.
Okay. And there was one question on technology platforms and partners using for screening and referral. There's a lot of technology platforms that are being used. If you've seen it, they're being used here. Find Help, Unite Us, the Health Information Exchange, PCIC. I mean, it's a long list. So the screening is largely done in the electronic health records, so whichever EHR folks are using. And then there's a whole host of tech platforms that organizations are using for the referral side of things. I don't know. I do have one question, perhaps for our Chilpi colleagues. Do you have any thoughts or comments on the community health worker billing side? There were several questions on that. I know that's, of course, different from House Bill 26 and Senate Bill 25, but any thoughts on that from perhaps other states?
In terms of like how it works,
sorry.
or
No, just we have, House Bill 1575 that was passed for CHW services reimbursement. And I don't know if there were any learnings from any other states in terms of some of those. And if there's any information that we can look up and share with the group.
certainly we can share some information with the group about learnings from other states. I know Heidi's on the call and has a lot of learnings from Texas about community health workers. There's certainly a role for community health workers in this work, as was highlighted in Josh and Jasmine's presentation. And there's a lot of parallels, right, with the integration of community health workers into Medicaid with this work, because like with nutrition providers, community health workers also do not have a clear path of integration into Medicaid. So a lot of those learnings that groups like your group led by Heidi, they had to follow really similar pathways of implementing that legislation that you all will have to follow in implementing this legislation. So I think answering those questions and taking those learnings from that legislation to this will be really important. So happy to pass along information from other states there, but I think Heidi will be the best contact and other folks on this call for what happened in Texas.
Yeah. Well, with that, we are at time. So just want to thank our wonderful speakers and Naomi and Heidi for joining the webinar today. And thank you everyone else for taking time out of your lunch hour to spend with us. And I think the questions were incredible. We'll share out the recording. If you want to learn more about some of this work, feel free to, again, visit the website. We have the QR code. We have a community health worker network that is very active and working through some of these questions. We have the Coalition for Connected Care that where a lot of these conversations are happening around how do we coordinate care better. So feel free to look us up and join, and we welcome those conversations as all